I'm curious. I am curious. Curious.
By nature.
Welcome to Curious by Nature. I'm Jessica Johnson from Newswise. What if brain scans and artificial intelligence could predict psychotic episodes? There's a new frontier in mental health research using functional MRI and machine learning to examine the experience of patients in psychosis. Decoding brain activity is a complex puzzle that requires a new way of thinking about psychiatric illness, not only in terms of behavior, but in terms of networks, circuits, and connectivity. Our guest today is an engineer by training who now works at the intersection of neuroscience, psychiatry, and artificial intelligence. He's using advanced imaging tools to understand how data can help predict the signs of psychosis, such as delusions, hallucinations, and cognitive dysfunction. In the bigger picture, what they discovered could bring us one step closer to more personalized predictive mental health care. Dr. Scheinost, welcome. Please tell our listeners a little bit more about your work.
I'm Dustin Scheinost. I'm from Yale University or Yale School of Medicine. I'm in the departments of radiology and biomedical imaging, where I am an associate professor. I am curious about how can we extract more information from functional neuroimaging measures to better understand the brain and mental health.
And can you tell me more about your work and what you do there?
Yes, I do several different things, largely involving neuroimaging. So imaging of the brain, mainly with MRI and mainly functional neuroimaging. So, using MRI, we measure brain activity and look at the spatial temporal patterns of that. What we particularly do is develop new ways of extracting information from those images, and then trying to use that information to relate it to various uh, mainly mental health related aspects. So, what relates to symptoms, things like that, but also broadly cognition and kind of other areas of, social, emotional, things like that.
It seems like also from what I was reading about you that you are bringing in AI into your work. And so it's a really interesting kind of roles and people's roles and like what kind of your focus is, but then adding on these various layers of other disciplines. So could you say something about that?
Yeah, well, so I'm an engineer by training, right? I've been an engineer my whole life, so I still do engineering, right? So that's where a lot of the machine learning or AI or bringing those aspects come in. I'm an amateur neuroscientist, right? So that's where it all kind of comes together. But yes, that's part of what we do, right? Designing new algorithms to explore the data, right? Those can come from very data driven, very machine learning, very AI inspired ways of doing that. And they can also come from very kind of theory based on the neuroscience ways of doing that. But yes, the whole idea is, can we use better methods or more powerful methods to pull out more about your brain to, relate it more to your behavior to understand things a little bit better.
I found out about your work through an article on Newswise that was distributed and was really interested in talking to you more about it. So could you tell me about that paper in neuropsychopharmacology that was recently published?
Yep. So that paper is looking at psychosis, both early psychosis and chronic psychosis. Largely the difference between those two is just how long you've had psychosis, right? I think in the paper we operationalized early as somewhere around 5 years or less. And what we did in that paper is, obviously we did, as I've been saying, functional neuroimaging. So functional MRI scans in individuals with psychosis, with early psychosis, chronic psychosis, and, typically developing their subjects. And what we looked at in there is whether or not we could predict their symptoms from their neuroimaging data. And then whether or not you could cross predict symptoms from those in early psychosis to those with chronic psychosis and vice versa. And there's a kind of couple interesting things there, right? While early psychosis and chronic psychosis are generally fairly similar, there are differences, right? Some of which are simple symptom severity. Some of them are also response to treatment, right? Those in early psychosis, if we can out them out sooner with treatment, they generally do better. So there's this kind of question, are they the same? Are they different? We kind of looked at that by trying to predict these symptoms and then see if how you can cross compare. Um, Not surprisingly, we didn't get a simple answer. Nothing is simple, right? While in each group, we could train these machine learning models to predict someone's symptoms. So, for example, let's say a new person with chronic psychosis or early psychosis came to me, we could scan them, we could pull their data into our algorithms, and we could get a good estimate of what their chronic psychosis score or their psychosis scores would be, their symptoms profiles would be. But the models only had limited generalizability across the two groups, meaning if we trained a model based on early psychosis and applied it to chronic psychosis, it didn't work. Interestingly, when we trained models in chronic psychosis and applied them to early psychosis, some of those models did work. So it's kind of a complicated picture of a lot of things were similar between the models in terms of what brain features predicted. But in general, we saw things perform better in chronic psychosis, lining up with that, chronic psychosis being similar, but a more kind of severe version of it, if you will.
So can you explain more, I guess, what you were looking for? Like when you say that the models were more predictive for psychosis, and what were they predicting?
Yeah, so we were predicting the PAN score, which is a kind of classic, kind of gold standard measure, behavioral measure, symptom scale of psychosis. And we are able there's kind of a couple of subdomains. There's positive symptoms, positive domains. Those would be things like delusions, hallucinations, those aspects. There's also the negative symptom domain that kind of comes with let's say some of the cognitive deficits associated with psychosis. And we were able to predict both of those. We got better predictions using the chronic sample.
So you said that that prediction of the symptoms happened more with the chronic psychosis patients than the early psychosis patients.
Yeah, we could predict in both groups independently, but we saw a stronger association. So basically, just that the prediction values were better, they were more accurate in the chronic psychosis, or the brain data better related to their symptoms in the chronic sample.
So what would be the next ideal study that you would want to do based on the results of this one?
One of it's kind of more boring, right? And that's just more subjects, replicate it more, keep testing it, right? That's one of the kind of the things I think sometimes in our field of neuroscience or neuroimaging is just testing the robustness of these models, really pulling them through a stress test, see when they generalize, when they don't generalize. We know they can pick up on various biases in the data or only work in special subpopulations and things like that. So really testing them. The more interesting from maybe that's the interesting engineering direction, the more interesting neuroscience direction would be to start looking at whether it's these models or develop new models and even earlier in the pipeline, so to speak, right? So the transition, right, going into psychosis, right? There's early psychosis where it's right after your first episode of it for a couple years, but then there's prodromal psychosis too, right? Where you might be at high risk, high clinical risk for developing psychosis, but you might never develop psychosis. And tracking back these networks that we found, can we predict either who's going to develop psychosis from some of these models, right? Can we predict more treatment outcomes with some of these models? Even if we don't develop new models, can we look at some of the brain features that we found and can we track them longitudinally over the course of someone's, clinical psychosis, right? So if we could track someone before they have their first episode, so someone at high risk, we could look at these features longitudinally and how do they change as someone has their first episode of psychosis? How do they change as they move from their first episode to second episode to a more chronic disease, right? So looking at how these things progress over time would be probably the more interesting neuroscience approach.
And so for you in neuroimaging, what is it that you would most likely want to see? Maybe not in the next study, but what do you want to get to be able to predict certain who will have it? Or I don't know, what were you looking at?
Yeah, so it would be any of those, right? So it's if you could we're still a little far away, so I do want to cautious that. That's not like you're not going to run out tomorrow to do that, but that would be a lot of the ultimate goal is if we can with our neuroimaging measures help predict outcomes for folks, whatever those outcomes might be, right? So is it going to be converting from prodromal to first episode? When that's going to happen. Maybe it's predicting who's going to do well on a treatment response or not, right? That can be a very low bar. If you have a very high intensive therapy, a high cost therapy, and you have a lot of people who might be wanting to go do it, if you could just even not predict who's going to be successful, but just predict who's not going to be successful, and then you don't offer that, that can then help guide that person into, something that might work for them. So those are kind of what we would ultimately want to do to help guide people to the right treatment. But that's a little far as off right now.
I mean, is it possible now that you look at, let's say, images of the brain and you're able to see people that are at risk for psychosis?
Yes and no, right? So it's a bit complicated. If we look at people at high risk for psychosis, they do see brain patterns that are different than those at low risk for psychosis or just typically developing kids and, late adolescents. So we do see differences in there. How predictive those differences are of worse outcomes, or any outcomes is still a bit murky, right? There's evidence that some of those things do. Um, but, there's a lot of other factors that go into there. So we're not quite there in terms of being exactly able to do it, but I think there's promise to do it.
Is it kind of like having a gene that predisposes you for cancer, but it might not?
A little bit. That's not a bad analogy, right? Like, so when for genetics first started, everyone was thinking, oh, there'd be this gene and that gene. And then the picture got more complicated. And then you have a set of genes and you have a risk score based on those genes. And then you have the interaction between the gene and the environment and all that. We're in a similar boat, right? We have features in the brain that we think probably convey risk or convey resilience to certain things, but they interact with so much, right? The brain's a very flexible too, right? You can train your brain to do things, you can improve things, you can take medications, all those are going to affect your brain, right? And the signals we see. So that's where a lot of those things get a little tricky. And then we're also just starting to understand all the different, individual differences in the brain, in terms of all the background exposures, lifestyle choices, and all those, how they affect the brain. Um, and, we deal with small effect size, right? So, you know, as you said, with small risk, doing this might increase your risk for something, but it's probably only going to have a small change to your brain at any particular point, right? And so, it's picking up on all these small signals and trying to pull them together.
How did you decide to get into neuroscience and into neuroimaging?
Um, kind of dumb luck, like most things, I would say. I got exposed to medical imaging my last year as an undergrad in engineering. I kind of just liked it. But that was general imaging, right? General medical imaging, nothing kind of specific about the brain. Then I got my first job out of college. It was working at Yale in a research lab, and we were doing image guided neurosurgery. And so, I was in the OR kind of looking at some stuff, right? I've been to probably about 50 to 100 neurosurgeries over my life. Um, and so that got me more and more interested in the brain, right? So how medical imaging can actually have, affect clinical practices and especially things on the cutting edge of it, right? So there it's trying to figure out these new imaging modalities to see if they can inform, image guided surgery and things like that. And that's kind of the first foray into really neuroimaging. And then from there, just kind of refining the interest, picking up that a lot of that was kind of structural imaging. So moving on to more functional imaging and then, yeah, kind of just bringing the two together.
And what about psychosis? Why did you decide to study that particularly?
My student was into it. bluntly. We do a lot in mental health kind of research, psychiatric research, things like that. I'm very interested in that, but I'm fairly disease or disorder agnostic. So I'm not a particular expert in psychosis or depression or anything like that. So it's a little bit of where the interest of our collaborators are, and where the students and postdocs and people kind of on the ground interests are. So in psychosis, again, probably just dumb luck that we picked that topic for this particular paper.
I mean, I think one of the important things, though, is that when you're able to see that someone has early psychosis, and then how does that develop into the chronic psychosis? And are there ways to heal their psychosis so it doesn't become chronic? Is that something, I mean, I know you're not particularly, that's not your focus, but do you see that, or how does that relate to neuroimaging?
These conditions have these time courses. They tend to get worse, not always, but what you would like to do is for them not to get worse, right? That's a very easy and obvious goal. A lot of times the treatment for these are based on, clinician um kind of experience, right? I hate to say guesses, but sometimes it's not much more than that on really where the best avenue to go on various things. There also can be a lot of misdiagnoses. A lot of these psychiatric conditions have overlapping symptoms, right? So it might not be exactly clear what bucket you fall in, or whether you should even fall in a bucket or across buckets, right? So then the hope is with the neuroimaging, it can help guide what bucket to fall in or help guide what we should be thinking about, right? I mean, that's the kind of long-term goal for it. Sometimes with even the shorter term goal is if we can figure out what circuits might be uh different between early and chronic psychosis. So like what brain features, right? If it's brain region X only shows up in early psychosis, but not in chronic psychosis, maybe that's the region we want to target. So if we know various therapeutics interact with that brain region, then we can think more about more targeted approaches for that.
That's great. I mean, I think that it seems like, I don't know the data, maybe you know the data better, but in terms of mental health and psychosis, it seems like the numbers are rising.
Yeah, unfortunately, for a lot of mental health conditions, I think that's roughly true. There's a whole host of reasons for that. One of this is just maybe better knowledge of these things, what the symptoms look like, and more access to care. But there's a whole other set of theories on them. But yes, they are very serious conditions. In terms of they affect a lot of people and they do reduce life quality. So if we can improve anything, that'd be great. And, as you said, they're surprisingly common.
There isn't a lot of support for many people, so if they can get that early support, and if it can be diagnosed early through imaging and kind of have that predictive aspect, that could be so helpful. Is there something that I didn't ask you that you would like to respond to?
I mean, I guess the only thing I should say is a shout out to Maya Foster. She's the first author of the paper, the student who kind of, had the idea to go in this direction. So I should make sure I shout her out.
So one Dr. Scheinost.
Curious by Nature is a production of Newswise. More than 7,000 journalists get the Newswise wires. Visit newswise.com and find out how to spread your news today.